Welcome everyone to Deafblind Information Australia's webinar, Orthoptics and Congenital Deaf Blindness. I am your host, Melanie Robertson. I join you from the lands of the Whadjuk people of the Noongar Nation, and our presenter joins you from the lands of the Wurundjeri people of the Kulin Nation. I acknowledge these and all other traditional owners of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to them, their cultures, their elders past and present, and to all with deafblindness. Joining us for this webinar is an orthoptist based in Victoria, Australia. She is the owner and operator of an orthoptic practice, a university lecturer, and co-founder of the CVI Community Australia. With her commitment to the betterment of services for people with blindness and low vision through research and teamwork, and with a particular interest in paediatric vision and neurological vision impairment, she has much to offer people living with deafblindness and those in their networks. Her presentation will be followed by an opportunity to ask questions. Please only use the question and answer or Q&A function. You can let us know via the Q&A if you need your camera turned on to sign your question. It is now my great privilege to welcome Natalia Kelly.
Hello everyone, and thank you Melanie for that beautiful introduction. Today our webinar is on orthoptics and congenital deaf blindness, with a particular focus on the orthoptic role and functional vision assessments. Again, I'd like to say thank you to Deafblind Information Australia for recognising orthoptists as part of the deafblind community. The orthoptic discipline is not really well understood by many people in the general community, including health professionals. So I hope today will raise awareness of how orthoptists play an integral role in deafblind early intervention and support visual development. So this slide is titled Outline. Today I'm going to clarify what an orthoptist is and the scope of my discipline. This will then follow into services that we provide, into the service that we most recognise for, which is functional vision assessments. Additionally, I will outline some considerations when supporting deafblind children. This slide contains a profile picture of a much younger me, on the left in a pink dress, and the text on the right there's text on the right of the slide. So a little bit about myself is I'm a rehabilitation orthoptist with a private practice. I specialise in vision rehabilitation of people of all ages with complex ocular and neurological vision impairment. I'm also a lecturer at La Trobe University, a co-founder of Cerebral Cortical Vision Impairment, or CVI Community Australia, and a member of the Paediatric Vision Impairment Alliance Australia. The image on the right is a slide of a white puzzle with a central puzzle piece joining the two sections. The slide is titled, "Why are orthoptists important in congenital deafblind in the congenital deafblind care pathway?" Before I answer this question, I will first explain what an orthoptist is for the participants who are not necessarily aware of us, and our scope of practice as well. So this slide is titled The Orthoptist Overall Role. There is a picture of a little boy to the right of the slide with a wide, happy smile, holding an apple and sitting in the front of an eye chart. Orthoptists are one of the 4 O's that are found in the eye healthcare system. So commonly people are aware of ophthalmologists, which are eye doctors, and optometrists who play a vital role in early detection of eye disorders and specialise in prescription of glasses and contact lenses. There are also optical dispensers, and they are the ones that make glasses and contact lenses. And then we have orthoptists. So the orthoptist's role in the eye health system is quite varied. We are university trained allied health professionals who need to be registered and accredited with the Australian Board of Orthoptics in order to practice. So many orthoptists work within a 3-tier health system along ophthalmologists in private and public hospitals and in clinics. Orthoptists also work in rehabilitation. This area allows orthoptists complete autonomy of patient care, and there is a mutual working relationship with optometrists, medical specialists, other allied health professionals, educators and support workers, to name a few. There's also a wonderful increasing trend of orthoptists starting private practice, which is a great push forward for my discipline. The title of this slide is Scope of Practice. The left of the slide shows a Venn diagram with 3 circles titled Medical, Low Vision and Rehabilitation, and Ancillary. The scope of orthoptic practice generally is quite extensive. Majority of orthoptists work in the medical field, where they are involved in the assessment, diagnosis and therapeutic management for eye conditions, ocular motor disorders, binocular functions, and visual processing dysfunction. Some of us are also skilled at performing electrodiagnostic tests to help with the diagnosis process. Some orthoptists independently run preschool vision screening and non-surgical management of pathologies or eye conditions. Rehabilitation orthoptists also conduct assessment of vision to investigate the level of loss, as well as providing intervention to optimize vision and help integrate vision with other functions and senses. This includes management of neurological vision impairment. Ancillary supports. There are many orthoptists doing amazing research in leading research institutions in Australia. Orthoptists have led the way in artificial intelligence technology, which is changing the diagnosis pathway for many conditions, including diabetic eye disease known as diabetic retinopathy. Orthoptists work in academia and are also involved in public health policy decision-making. The title of this slide is Scope of Practice Relating to Congenital Deaf Blindness. The right of this slide shows a table of arrows pointing down. Each arrow is titled Moving Down. The diagnostic, each arrow has a title moving down. We have diagnostic, treatment and management, and rehabilitation intervention. Congenital deaf blindness is a unique dual sensory impairment resulting from a combination of both hearing and vision impairment existing since or before birth. Congenital deaf blindness can be due to various causes, including viral infection affecting fetus development, genetic or chromosomal disorders, complications at birth, autoimmune conditions, or acquired from injury to the eye and ear or brain. Congenital deaf blindness may not necessarily be caused by impairment of the structures of the eye and ear, but also linked to visual and auditory processing dysfunction as a result of neurological brain involvement. So in relation to vision, the impairment to vision can be present at birth or shortly after birth, as seen in children who are born with Charge syndrome and have coloboma, which is an underdevelopment of the eye. Or vision loss can develop later on in life, seen in certain syndromes and inherited conditions such as Usher's, where the retina starts to degenerate or break down towards the end of the first decade of life. So we're looking at around about 10 and the early tweens. Vision impairment, whether it be eye or brain, can adversely impact global development. The effect on development is greater the earlier the onset of the condition. So therefore, orthoptists have a unique skills that are vital to support people with congenital deaf blindness from being part of the diagnosis process and treatment process, supporting families with information pertaining to their child's vision, and implementing appropriate vision intervention and ameliorate visual development. So how? Orthoptists are trained in understanding how the structures and functions of the eye and brain work. They also know how to assess for anomalies and are aware of how change to vision and visual processing can impact general development and participation in activities of daily living. Orthoptists are able to screen and monitor vision of children who are suspected of deafblindness or who have a diagnosis of deafblind condition where the vision loss occurs later in life. Being able to detect vision changes early will assist in timely treatment and therapeutic intervention to minimise impact on learning and development. Usually when a child goes to see an ophthalmologist, they will see the orthoptist first. So the orthoptist is the one that checks your child's vision and takes pictures and scans of the back of the eye to identify any changes and also evaluate the integrity of the eye structures. They may also do electrodiagnostic testing of the retina and occipital lobes, which is the visual center at the back of the brain, to see how well the nerves are working. So the tests the orthoptists conduct are essential in the diagnosis process and directs pathways for treatment and management. Generally, children born with syndromes or neurodevelopmental conditions have a higher incidence of having reduced vision, turned eyes, and are more likely going to need glasses than a typically developing child. Orthoptists are able to assess the need for glasses and help the management of ocular motility disorders. Rehabilitation orthoptists as part of an allied health therapy team is sometimes actually overlooked when supporting a child with congenital deafblindness. So we are most commonly known to conduct functional vision assessments. However, our skills do actually expand further than this to also encompass therapy to support visual development, aid in binocular vision, optimize visual functions, and support visual integration with movement, language, emotion, theory of mind, higher executive function, and other senses. The image on the left of the slide is of a little girl wearing glasses looking at a transparent red ball. The title of the slide is Orthoptic Functional Vision Assessments. Before I go on to talk about functional vision assessments, I want to start by showing you some simulations, so this can hopefully provide some insight when talking about vision and development and the need for a comprehensive functional vision assessment. The vision simulations on this slide here show a red double-decker bus with a man in a blue top riding his cycle. The simulations are based on visual acuity changes, and visual acuity is a measure of detail vision. It is represented in a fraction, and the top number is the testing distance, and the denominator is the measurement of detail and indicates the level of vision impairment. A large number at the larger the number at the bottom, it indicates greater vision loss. So the image on the left simulates 6/6 or 20/20 vision, while the image on the right shows slightly blurred replica of what someone with 6/12 vision would see. 6/12 is minimum standard for driving. On this slide, we have the same image of the red bus and cyclist. The image on the left simulates 6/6 vision, while the image on the right shows a more blurred replica of what 6/24 looks like. This level of vision is classified as low vision. So while you can make out the image, I would like you to consider how it would be having to tolerate seeing a consistently blurred image. Likely, visual reserves are going to start to diminish and the ability to sustain vision becomes harder. Sticking with the same image of the red bus and the cyclist, the image on the left simulates 6/6 vision, while the image on the right shows a more blurred replica of what 660- looks like. This level of vision is classified as legal blindness. As you can see here from the form of the cyclist is now harder to see and the writing on the bus is no longer legible. The final simulation slide of the red bus and cyclist, the image on the left simulates 6/6 vision, while the image on the right shows someone with 6 on 120. This level of vision loss is classified as severe vision impairment. The form of the red bus is present along with the contrasting black windows. However, if you didn't originally know that this was a bus, it would be hard to decipher the object. So additionally, it's quite difficult to now see the cyclist riding next to the bus. So this is a slide. This slide has a number of icons showing signs for vision, movement, language and communication, social interactions and relationships, learning, emotional development, and cognitive development and memory. The bus and the cyclist simulation helps us see how vision can start to really impact quality of life and fatigue levels as well as other functions. For most of us, vision plays a vital role in development, as it is the primary modality that integrates the senses and many functional systems together. The harmonious integration of vision into functional systems is essential in developing skills of daily living. Daily living is not only confined to the ability to perform certain tasks, such as reading and writing, personal care, independent orientation and mobility, etc. It also involves the individual's self-concept and their ability to observe and interact with society in various contexts and environments. So therefore, vision loss early in life can critically affect areas of movement, perception, cognition, social interpersonal, emotional, and language development. So for example, vision initiates curiosity and provides the motivation to move towards a desired object. We use vision to help the development of the motor pathways to discern and coordinate limb movement and limb and head movement. So vision also provides us with access to incidental learning, which then feeds into building our daily living skills. So for example, no one really explained to us how to open a door. We use vision to observe this action on numerous occasions, and then when given an opportunity, we're able to mimic the action. So vision also plays a pivotal role in communication and language development, as well as supporting social interactions, such as learning to use gaze direction during conversation. And we even use vision through and gaze direction for flirting. So for many of us, we are also visual learners. This allows us, this shows you how vision is interlaced with the memory system. So memory is an essential criteria for learning. Without memory, we struggle to build knowledge because we need to have access to the base foundation of information that we can retrieve from our memory. So the image on this slide has 3 icons: an eye representing visual function, a camera for observation, and the play symbol for functional vision. Functional vision assessments are offered by a range of professionals, both eye healthcare and non-eye healthcare professionals and educators. It's important to understand that while the same term is used, so functional vision assessment, there is a difference between the assessments. A non-eye healthcare functional vision assessment should not be confused with an orthoptic functional vision assessment, as the information obtained from these 2 types of assessments is actually different. So essentially, a functional vision assessment by an eye health care professional, such as an orthoptist, we're able to perform selective clinical and modified tests based on our knowledge of the visual system to obtain a comprehensive outline of vision and the impact it has on function. So orthoptic functional vision assessments are moulded for each child in accordance to their pathology, coexisting conditions, and whether or not the brain's involved. The skills to customise the assessment is really important when supporting a child with congenital deafblindness. And this is because vision is affected in different ways because there's so many different types of deafblind conditions. Some conditions affect the peripheral vision, while other conditions cause blurred vision. And then you also have variations in vertigo to consider. Essentially, when conducting a functional vision assessment, we're gathering information about different parts of vision, but we're also interpreting how this may be a barrier for development and learning. The information obtained is then used to implement recommendations and strategies to mitigate against the reduced vision. An orthoptic functional vision assessment for an ocular pathology is composed of two main components, so observation and clinical assessment of functional vision. Together, this information informs the orthoptist about how the child uses their vision to perform various activities and how they are likely to engage in different activities. The information on this slide has 4 icons: a camera for observation, eye to represent visual function, brain for visual processing, and the play symbol for functional vision. A functional vision assessment for a child with neurological vision loss takes on various complex factors. So I will only briefly talk about brain-based orthoptic functional vision assessments just due to time. So with neurological loss, it's important to investigate the extent of both the ocular and neurological impairments. The testing conducted looks at additional factors that impact visual ability. So orthoptists have different approaches to assessing neurological vision impairment, and this is based on their experience and their knowledge. For me, my assessments are composed of 3 elements. So first, I evaluate visual function to assess the quality of vision and the integrity of the primary visual pathway. And this is usually done using clinical tools. I then explore visual processing difficulties to identify the extent and level of visual processing, identifying both intact and insulted areas. Finally, functional visual ability is determined by observing how the person uses their vision to learn and interact with people and objects in their environment. So visual ability is informed by visual function, and visual processing to explain how and why the individual approaches and performs certain activities. The outcomes of these functional vision assessments can then inform intervention approaches to meet the child and family needs. So this slide is titled Functional Visual Function Clinical Assessment. It has an image of an eye test on the right and a list of visual functions on the left. The visual function assessment is the clinical component, and it's the most straightforward part of the assessment, really. So we assess all domains of vision, including acuity, which is detail vision, contrast, which is how faded something is until it disappears, color vision, visual fields, depth perception, in particular stereopsis, and that's your 3D vision, and ocular movements. So in congenital deafblindness, it's also really important to assess the more complex ocular motor systems, such as the vestibular ocular system. So the vestibular ocular system is closely linked to structures and innovation to the year, and therefore it's commonly affected in deafblindness. So there is an array of different clinical tests that we use to obtain information about the integrity of vision. For each of these tests, for each of these components, there's a variety of tests that we can choose from. So the testing method can also be modified to suit the child. So for example, we can use a clinical test where the child would have to read letters or see shapes. And then within that, even it depends on whether or not we're presenting one letter or a line of letters to the child as well. That gives us additional information. And we also can use Lego blocks to and ask them to find certain Lego pieces or Lego shapes, Lego sizes. And that gives us some information about their acuity too, in a more functional sense. For some children, some tests are more heavily weighted to extract the extent of vision, the extent of loss. For example, in children with Aicardi syndrome, we would pay closer attention to their acuity, visual fields, contrast, colour, and pupil function. So closer attention may be maybe towards visual fields, because in children with Aicardi syndrome, they have two types of conditions that can affect the visual field. So coloboma is one, and chorioretinal leucania, which is small holes in the retina, is the other. The reason why we would check pupil function as well is because the brain is involved in Aicardi syndrome, and abnormal pupils can contribute to difficulties with glare and detail vision as well. For those who also present with an eye turn, we would look at the ocular alignment, a range of movements, visual fields, and also the need for glasses. It's important to note that the need for glasses, particularly in children with eye turns and neurological loss, is not so straightforward. There are a number of considerations that need to be explored to see what will support visual ability and also binocular function. So for those that present with vestibular dysfunction, such as seen in Usher syndrome type 1 and possibly type 3, CHARGE or Cogan syndrome, or even those with acquired strokes, we would look more closely at the visual fields, their oculomotor system, and also the visual vestibular system that impact on both stationary and dynamic, so sitting and moving function. So while visual functions are most closely examined, while some visual functions are more closely examined, it's important to make sure that all of the visual functions are assessed to see how they work harmoniously or inharmoniously together to learn about the impact on development. So this slide shows a table that lists visual functions on the left and offers possible functional impacts on the right. So I thought this table might help you better understand the impact on function when different parts of vision start to change. So when we have reduced vision, the tasks that are most likely going to be affected are reading, writing and drawing, playing with toys that have detail, seeing images and detail of pictures and books, and seeing images on iPads or portable devices. Visual field loss is also commonly affected in congenital deafblindness. So visual fields can cause difficulties with general orientation and mobility, whether or not it's in familiar or unfamiliar environments, depending on the level of loss. It can also create night blindness. So really significantly reduced vision, or they won't be able to see at all in dim or dark environments, and also having difficulty locating objects as well. So people with constricted fields or loss to the visual field also lose the context of what they're looking at. So that needs to be considered. So reduced contrast sensitivity. Social communication, it will affect social communication. So seeing faces, facial expressions, and also nonverbal cues, potentially seeing their meals on their plate, seeing pictures. So seeing meals, for example, if you were to put Weet-Bix in a white bowl, that would be really hard for someone with reduced contrast to be able to see how much and whether or not there's any left as well. So seeing pictures and toys and objects used for daily living can also be challenging too. So for example, pouring water into a clear glass might create challenges in those with reduced contrast sensitivity. So changes in colour vision could impact visual search because we use colour for visual search and seeing segmentation. Also craft and play, it will also be impacted. Reduced binocular functions can cause headaches and eye strain, so we need to be mindful of that. So difficulty with depth perception and increased risk of falls, and it may also impact reading ability. So vestibular dysfunction can cause dizziness, nausea, and also excessive fatigue. It can impact on posture and mobility, and impact on play and socialization. So the impact on play and posture, those kind of things, is because they have difficulty seeing where their head is moving in different directions. So this slide is titled Observations. Top right image shows stacked picture blocks, and the image below that is of a little child playing with toy cars. Through observations, we are looking for multiple cues about how the child uses their vision to learn and interact with people and objects in their environment. For example, we're looking to see how attentive the child is and what distance they're able to see different sized objects. Also, what distance they are able to see to recognize someone's face or even facial expressions. Does the object need to be moving in order for them to see it? Or conversely, does it need to be stationary for them to be able to see it? How are they able to navigate their environment? Does lighting and glare impact their function? And importantly, we also look at their level of engagement, changes in behaviour, and also their fatigue levels. And this gives us information about their functional reserves and stamina. So how long can they use their vision before they start to tire? And then you'll start to see visual attention and potential behavioural challenges coming forward. The combination of visual function outcomes and observations help inform our perception of their functional ability. So for example, we would use information about their depth perception and contrast to inform function about certain tasks and whether or not vision is sufficient to complete the task, or do they require sensory integration to assist. So for example, helping a child being able to pour a glass of juice. So do we have enough information to see if increased contrast will be sufficient to overcome the reduced depth perception? So we'll assess contrast and depth perception for that task. Or does the child need to consider proprioception and tactile feedback when pouring a drink? And the testing will be able to give us that, along with observations as well that we observe through play. So this slide is titled Clinical and Therapeutic Therapy Considerations for Supporting a Child with Deafblindness. There's a segmented circle on the right with each wedge containing the title, and the titles are family and support systems, coexisting conditions, example, cerebral palsy, epilepsy, ASD, global developmental delay. Another title is personality and behavioural traits, environment, and needs and goals. Whenever possible, the child should be accompanied by a familiar person, so ideally a patient, to all appointments. This person will be the cornerstone for your session, as they will provide the child with feeling safe and secure, especially if the session is in an unfamiliar space. They will also be able to assist you interpret observations, aid in understanding the child's behaviours, and help be an intermediary for communication if needed. Orthoptic therapy is driven by the needs and goals of the child and family. Also, understanding the family structure and supports around them is important when asking them to implement therapy tasks between sessions. Ideally, therapy tasks should be designed to slot into daily routines to reduce the burden. There are a number of environmental considerations that need to be factored when supporting a child with congenital deafblindness. Having a controlled environment is really important to ensure that there are minimum distractors in order for the child to use their vision. Conducting the assessment in a familiar environment will significantly support the child being comfortable in order for them to be able to participate. When this is not possible, then you will need to consider giving them time and information about the space around them before being able to interact with them. This will also allow them time to be able to be comfortable in your presence. Seating the child with consideration to lighting and glare sources is also important. So making sure they don't face a window or their back's not towards the window, but ideally they're sitting next to or parallel with a window. Regardless of the level of hearing impairment, peripheral conversations and background noise should also be minimized, as it will create barriers for clear communication and also comprehension. So consider that the brain has to work harder in order to filter competing sounds and simultaneously process reduced information from hearing and vision. Consider that if a child is undertaking a session in an unfamiliar environment, surrounded by strangers with strange smells, sounds, sights, and textures, they are likely to tire easily. So providing interval breaks during the session is very important in maintaining engagement and also rapport with the kid too. The child's personality and behavioural traits also play a role in how you interact and support them. Observing the child and understanding their behaviours will provide insight into how they need to or prefer to engage in activities. Consider the use of touch cues to support interaction. However, care should be taken when using touch cues. Touch may be a significant sense for the child to be able to access and interact with their environment. So make sure that you maintain a safe environment and also send the right communications. So in order for you to be able to do this, it's important to allow the child and parent to help guide you when using touch cues. So this slide is when to have an orthoptic functional vision assessment. There is an image of a little boy sitting on the bench laughing as he holds a book. There are different times to request a functional vision assessment. So initially the assessment should occur shortly after a diagnosis or even after a suspicion of a diagnosis of vision loss as well. I'd also seek a functional vision assessment if you as a parent suspect, or as a therapist suspect, that the child is having difficulty using their vision, or you also see a change in their function as well. And the reason for all of this is early intervention is the key. So subsequent assessments are really dependent on the level of vision and the developmental stage. So the earlier the child is, I'd be looking at 6 to 12 months. And then the older the child is, maybe between 12 to 2 years. But some key points or key periods for a functional vision assessment would be before starting major educational milestones. So prior to kinder, prior to prep, pre-high school, and also pre-VCE are good points of assessment. So how does orthoptic rehabilitation supports? So what does orthoptic rehabilitation supports look like? The scope of rehabilitation orthoptics is quite extensive. The service offerings differ between non-for-profit organisations and also between private practices as well. So, and the differences can be due to different service models or also the skill sets of the orthoptists. But generally, rehabilitation orthoptists provide client and family education. Our role is to not only discuss information about the pathology, but how this impacts on the child's learning and development. The outcomes of the orthoptic functional vision assessment provides insight into the child's visual ability, and this information is used to formulate goals, which then inform strategies and recommendations to meet these needs. So to name a few orthoptic interventions, we would look at low to high assistive technology, such as optical or video magnification, lighting and glare control strategies, visual fatigue strategies, eccentric viewing training, which is teaching a child to use a different part of their retina for those with central vision loss, visual field awareness training for those with visual field loss, and exercises to support binocular vision. There are also play-based interventions to support visual processing development. These approaches are really individualised for the child, and they're also a little too complicated to summarise here. So depending on the complexity of the child and goals, orthoptists will work collaboratively with families, other therapists and educators to comprehensively execute goals. A multidisciplinary approach is not only important to provide holistic care, but ensure we're working within our scope of practice to meet our duty of care. So I hope this presentation has highlighted the important role orthoptists have in supporting children with congenital deafblindness and their families. I hope you've taken away some valuable information to help inform your future practice and also support your child. Thank you very much.